No, just press the go live. Go live.
Go live. Sorry, America. We're 2 minutes late because I'm late. But hello, everyone.
This is the Health Tech Talk Show. I'm Melissa Danilo. That's Kat. That's Lisa. That's Dan.
Yeah, here we are. So we've got a lot, we've been gone for a little while. I know there was a top secret, really fun talk show while I was on vacation. This is our first official one in 2 weeks. So we have some potentially real news to talk about. Well, we do have real news to talk about, but our opinions are potentially valuable or potentially not. And then we have Dan Nardi, CEO of Reimagine Care, who is a repeat guest who's back on to support us in our commentary after we go through our trash talking so that he is not held responsible for that. So Dan, anything to say before we send? Yeah, it's not his fault. It's our fault.
I'm here for it. I'm excited.
We'll talk to you.
Yeah. Yeah. All right, Dan, or you're out of here to remove any sort of drama llama. So
should we protect Melissa's chastity?
Should we protect Melissa? I feel like
yes. All right.
Yeah. Done. Okay. All right, Lisa. What even has been happening? Oh wait, hold on. Let me go back to the original. No, I spoiled it. Hold on. Well, actually, that actually wasn't that good. But anyway, here's our new show. So Lisa, what has even been going on? Other than the fact that we're crushing our fundraiser this week.
Yes. So thank you to everybody who has donated or shared information about the Zoria Foundation fundraiser. We set out to raise 4 full-year childcare grants, and we are exceeding that. We are gonna exceed it. We're gonna exceed it during this show. So that's great news.
We're basically crushing it. Yeah, and also I just want to say, so this goal says, so we are almost $58,000 of our $48,000 goal. To be clear, y'all, this is every time I have a call with a state representative in the South. 90 minutes into my 60-minute phone call, this is basically payback for that. We have exceeded our goal. But even our goal that launched on Giving Tuesday was already a re-upped goal that was another additional grant. Our goal originally was $36,000 or 3 grants. These are full-year childcare grants. It's $1,000 a month for 12 months, so $12,000 each for women working in healthcare to help them pay for childcare. So we thought we'd do 3 grants. I thought that was going to be kind of hard, because it's Giving Tuesday and
you were wrong.
We texted a bunch of people beforehand, always do, to line up some donors so that it's not just sad face. And we had a bunch of companies just come and knock some off. So shout out to Incenna, obviously, that's my company, but that wasn't just me, that was Leslie. Leslie was doing that. And then the whole company we always donate a lot. And then Castlemark Consulting, Kerry Newlish, the godfather of health IT, HIE implementations. He came in and was just yeah, I'll do 2. And I was like, what? And he was like, yeah, I'll do 2 whole grants. So God bless Carrie, that guy freaking rocks. Really and then helps. Michael from Arcadia stepped in with a big chunk of cash. Dr. Kavita Patel, also known as the Oracle at NEA, came in with a chunk of cash. Chris Klump sent us a check, but it isn't here yet, and he's not telling us how much it is. So it could be $5 or it could be $100 million. We aren't sure. I think it's going to be somewhere in the middle. But yeah, we had a ton of supporters here. So Lisa, of course, always donates all of her personal capital to Zoria Foundation. So anyway, but y'all, it would be really awesome if we hit $60,000 because that's 5 full year-long grants.
Yeah. It's a big deal. And one of the things that people don't understand potentially is, well, if you're a parent, you may know how much childcare costs, but then you should also look at what the salaries are, the hourly wages or the actual salaries of women who are working in healthcare roles that are not let's call it, just as a totally random, not related example, anesthesiologists. If you are a respiratory therapist, if you are a medical assistant, you are not making the big bucks, and yet you also somehow magically have to pay for childcare. It's not great. It's not great. And there's a big gap, and we are doing a little tiny bit to fill it here. We're giving the money that you donate to Zoria all the individual donations goes directly into the pockets of women working in these healthcare roles who are trying to pay for childcare and things like that. Right. So there's no admin. This is our admin. We are just a bunch of volunteers who do stuff.
It's like the clown show.
This is it, the clown show, but we're like committed to getting that money directly into the pockets of these women who need help with childcare and other caregiving needs. And so this is a good one. So thanks for helping. Thanks for sharing. It's been great this year.
Yeah, our average grantee makes about $40K. She has multiple children. She's almost always a single mom, and more than 40% of her monthly income goes to childcare, which sucks. Yep. So these are not like, no one's making the big bucks here. It sucks that we even have to like have a nonprofit dedicated to this, but guess what? This is America and we do. So go to these links that Melissa posted, ZoriaFoundation.org. You will not miss the donate button. I made sure it is real big and in all caps. Big. And donate money. Get us to 60K, y'all. All right. Okay.
You're so close.
Okay.
All right.
God bless America. All right, moving. Yes. Okay, so super terrible news, Lisa. Brian Thompson from United Healthcare, CEO of United Healthcare, was murdered on Tuesday.
Well, so there's so many things. Like the first time I saw this, I was like, wait, are we sure? Second, I was like, which one? Because he was the CEO of United Healthcare, the insurance arm. He's not the CEO of United Health Group. And then also, confusingly, United has, local market CEOs as well. So a lot of people have the title of CEO at a United Healthcare related company. As we know, it's this largest private healthcare company in the world, right? So massive, massive, massive. And wow, the reaction from the proletariat, not exactly what people were hoping for, I want to say. Not great.
Yeah, no, there has been like awful rage, and not in a way that's supportive of this man and his family. It's pretty awful. So yeah, so one thing I'll say I did that I have not gotten confirmation on. We, our guest for next week, someone from the NIH had to delay, and I wanted to see if Preston Alexander, who writes the Healthcare Breakdown, could come on the show and just talk to us about math. Because there are a lot of people who are like, fuck United, this is the reason people are dying. Listen, maybe that's true, but I also think like margins at health plans, while they do bring in a fuck ton of money, they're like in the single digit percents. So where is the money problem? Like, where is all the problem coming from? And so
a little bit of it. I want to remind everyone, our loyal fans, everyone else who's watching, our detractors, probably our haters, whoever in healthcare, everybody is a Spider-Man meme. We should put the Spider-Man meme up here, right? Where you can blame every other player, and we'll talk about that in a minute as well. I do think that the massive profiteering in healthcare is obviously a huge problem that is directly affecting people's lives. And that's why people are so mad. And also United denies a lot of care. They deny a lot of claims, and a lot, because they're so big, so many people, like just general people in the world, people in the United States have had like a claim denied by United. And that's just like, that's a function of math as well, right? This is a massive, massive player in their healthcare system. So people are reacting to that. Obviously, this individual did not deserve to get killed in cold blood in the middle of the city. But a lot of the responses are based on the fact that this is such a massive, massive company, and they do deny a lot of claims. So
yeah, I mean that's the thing too, right? It's like you see all these charts because again, like this poor man's death, his murder has been taken in a totally different direction, right? Like a lot of America is super pissed off at United and taking it out, right? Yeah. And you see all these charts, like the number of claims United denies as opposed to the other major insurers, and I think theirs is something like it's like 2 or 3 times above the other insurers. But again, it's so big, so I think there's a lot here that even we, we're at the clown show of healthcare. Like, we don't understand everything that's going on here. And I'm hoping that we can get someone on to just really break down the numbers for all of America to see, because all of America is watching this talk show, obviously, right now.
All of America. But also this particular case, I mean, this is just beyond the pale. This is wild, right there. There's an act of manhunt. This is happening right now. We have no idea whether this was truly a disgruntled, a patient or a family member whose family were harmed or killed, or whether it was
inside job,
something about in an inside job, insider trading, we have no idea. We have no idea what actually happened. From my perspective, just as a total, dumbass sitting on my couch scrolling through the news, it feels really tidy and perfect. So I'm going to join the conspiracy theorists, put my tinfoil hat on and say, I got my tinfoil hat on. I don't know. This is weird.
I agree. Something's up here. Something is afoot. So we'll see. I mean, the New York Times, as you can see, they've got a whole thing up here, up top in the header. So you too
live
can follow
updates.
along. Yeah, so totally wild. But speaking of people not understanding shit, let's talk about Anthem Blue Cross Blue Shield's clawback of their, or rollback of their recent decision to not cover anesthesia if a surgery goes over a certain time limit. So Lisa, this is an example of America not understanding things and headlines being taken out of context, and just perception is reality. Tell us more.
I read someone's comment today that I thought was hilarious. They were like, all of like the liberal online like people like got psyoped by the industry here on this one.
Yeah, I mean, if y'all are on TikTok too much, that's where you got your news about this. You don't know.
You are getting it wrong. I'm sorry to tell you. If you like the idea of Medicare for all, you should know that negotiating on like the price of services and things like a flat rate for anesthesiology for a particular procedure is like how you would run Medicare for all. And so the idea that Anthem in a horribly let me just say this goes into bad. This goes into like the worst comms. This is a contender for worst healthcare comms of the year, because the timing, they got unlucky, but also the way that they communicated it was so terrible. And they rolled it back and me like, oh shoot, sorry, we didn't mean to be evil. That's not the message. And I know a lot of people who've worked in crisis comms. They really should have employed some of them. This was not good. Basically, like Medicare has a time limit, not a time limit, but they say like, here's a flat rate for a procedure that we determine based on like how much time it normally takes. If you are just like consistently billing additional time, sure. As a patient, you're like, oh, well, I want to get an anesthesia for my whole surgery. That is a farce. You're going to get anesthesia for your whole surgery. It's just that they pre-negotiate the rates because they understand how long it normally takes. Sometimes doctors don't always do the right thing. Many times they do, many times they don't. You have to understand that like, this is how we get costs under control, is by negotiating the rates in advance, not allowing for massive deviation without any kind of other inquiry about that. So this was a psyop that totally worked. Like, I will say, like, congratulations. I'd like to shake the hand of the genius, the like anesthesiology professional society who did this one, because you, sir, I'm sure you're a sir. Congratulations. I cheers you with my Diet Coke. You won.
Yeah, that's actually what I thought when I read some, so this morning the Wall Street Journal did a nice little podcast or a section about this on their daily podcast. And they actually explained it pretty well. And it was from Anthem. And you're like, oh, that's it? Oh, okay. But then you saw, is it the American Society of Anesthesiologists, ASA? That statement, you can see where this campaign started. Holy shit. Like, oh my God. Again, I salute you, sir.
I do, because honestly, like they got it. They were able to pull on the like populist message at the very moment in time. And nobody read beyond the headlines. They were like, this evil insurance company wants to stop my anesthesia like 50 minutes in. Like, okay. Yeah. There you go.
Now,
you lost.
I don't want to say they took advantage of a man's murder, but I think they took advantage of a man's murder.
And you know what? And like straight up, they won. And I have to say, like, you did it. All right.
Yeah.
Spider-Man meme. Everybody's evil, pointing at each other.
All right. Moving on here. What do we got going on? Oh yeah, we went to the ASTP annual meeting, which may be the first and final.
But what was it? We're thinking about making T-shirts, right?
We're gonna be we're good at T-shirts. Best and final. Inaugural and only. I don't know. But we'll see. Yeah. So this was me and Lisa having a dinner that we didn't plan to throw with like 50.
But there it was.
And there's President Anish Chopra, who again is not the president of Arcadia, but the president of healthcare.
Yeah. Just to be clear, as we know, the CEO of Arcadia is a separate person who may or may not have been on our show recently, who we love, who we adore.
We do love dearly. Yeah.
But anyway, Anish is not that. But he is in his heart. He will be the CTO of America forever, and we support him.
That's right.
And we would nominate him for that role again too.
God bless America. But anyway, Lisa, what did we learn? This is the full health tech talk show is here. But what did we learn? What did we learn? What do I have next? Oh yeah. So what did we learn in general? And then we have some tweets that you really liked.
I once again learned that I like a lot of the people who we see and hang out with. Think they're all great. I think you're all great. I thought that this conference or whatever it was questionable. Weird timing. I mean, what are they going to do? They had it announced in advance. We're going to just cancel it or whatever. But weird to have a conference talking about this stuff when there's so many things that are on the table to change. It made a lot of sense to me to get together with my friends and colleagues, and that's kind of the end of it.
Yeah, it was really fun. I was there for like 6 hours. It was super great. But yeah, so we heard a lot of stuff. There was a lot of rah-rah, and like there's just a lot, like you said, there's a lot up in the air. So it's kind of like, are we just here to party? Yes. So, but Lisa, there were some announcements made, I think, in Mickey's farewell address, which I did not attend because I was there for 6 hours, but I heard it was very heartfelt, and he got a standing ovation and all that. So, but there were some things that he talked about in his final address, which I thought you would like to talk to us about, that Brendan Keeler has recapped for us.
Has summarized here. So first and foremost, it's about first thing is about benefits determination over the national networks. So first and foremost, I also support benefits determination for Social Security benefits over interoperability networks by electronic means. If you don't know, basically when they need to determine like whether someone's eligible for Social Security benefits for like disability or whatever, they do these like horrifying like manual chart reviews that take forever. They're super expensive. They're incredibly paper-based. They're super slow. People can die while waiting for their benefits determination. That's cool. Yeah. That's great work, everyone. We can do better than that. I will, however, say that eHealth Exchange has been live with the benefits determination use case for quite a long time. And there are ways to just increase the use of Social Security's eHealth Exchange connections for that work. The idea here is, can we, put live the TEFCA use case for benefits determination? Great. Let's do it. As everyone knows, I am pro more interoperability. Yay. But it doesn't solve the problems or like force people to use electronic means to do this disability benefits determination. And so like, again, I say, great. Yes, let's do it. Also, there's a big implementation gap as always. We have had the ability to do this for a long time. Why isn't it happening more? How do we make it happen more? I more care about that than an announcement that we're going to do the use case on TEFCA. Cool. Great. Let's do it.
Agree. Agree.
Let's do more of it.
Yeah.
Payer provider interoperability. Number 2 here. Sure. Yes. Remember how we just talked like 2 minutes ago about a battle between a payer and a provider specialty society? Do you think those guys like each other and like want to exchange data? They do not. And there's been some attempts and efforts and work that's been done across Da Vinci and from the different other groups and different, collaborative efforts as well. It is a really, 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 really tough nut to crack. And it's not about the technology as much as it is about people have business models they do not want to have disrupted, as Kat would tell us. Like, come on.
I mean, that's the thing, y'all. Like, we have to really think about how markets respond to things that aren't mandated. And how they respond to things that are mandated. Like, this is there's a market built around both of these top 2 use cases. And I do think like it'd be great if TEFCA did these things, but I also think let's work on solutions that are already in market also, and like see how that happens. Like, I'm here for all these things. I just think that we shouldn't ignore the things that are in place.
They're not happening because we don't have like the TEFCA use case live. Trust me when I say that. They're not happening because there are a bunch of people and organizations and systems and companies who are rent seeking in the market, who have a business, who are earning money, in some cases gobs of money, doing what they're doing right now. Like, this is not a technology problem. I'm going to tattoo it on my forehead. Like, please. It's not a technology problem. Okay.
Yeah, like all this, like God bless these standards people, God bless these Da Vinci people, and blah blah blah. But listen, that's actually not the problem, and this is already happening. It's already happening where there's financial incentive to do so.
Yes. Okay.
What financial incentive? Oh my God.
Number 1 and 2 are like things that we already can do technically that are not going to be this massive jump and leap in like, oh my God, we solved the world. Like, great, fine. Number 3, which So I wasn't actually there. Sorry, Mickey. I was gonna be there, but you moved your keynote from day 1 to day 2, and I was already gone by day 2. So I'm sorry. I would have loved to be there. I would have clapped for you. You're a great guy and you're working hard. But what I heard, and somebody can correct me if I'm wrong, is that from the stage in his keynote, talking about what they, plans were for TEFCA and what they've done, what they've accomplished, he said, wouldn't it be great if patients would get a notification when records about them were exchanged? And people were like, yes, yay. That would be great. Thing is, it's also incredibly complex to do. And there are lots and lots of B2B transactions that are happening about patients in the back end, where I'm pretty sure that those payers and providers do not want that data to be exposed to the patient, that they're actually pulling and requesting the data. Now, is it wrong? Absolutely. I am all in on patients getting access to their data. I want patients have the right to get that information. They should. It is absolutely bullshit that individual access services have been deprioritized in TEFCA, that they are sort of required, but not really required, that there's not this like accounting of disclosures for patient records. Patients deserve that and should have that. So I'm totally in on the idea, but I'm like, hey, I don't understand football managers. It's the end. It's the end of the game. It's what is the final?
You know what this is like?
Give me a football editor.
This is
Game is over.
I went on the talk show when I say, let's just let the fucking markets figure it out. When I say that kind of shit, that's what number 3 is, right? It's like the markets will figure it out. No, y'all, guess what? They're not gonna, because healthcare is an artificial market and it doesn't work like that. So that's kind of how
if you are saying this,
so
and you until very recently, you were in a very important, influential position in government, then sit down, because you were in charge of this. Come on. Like, I agree so much. I really want patients to have this, but it's one thing to say it and get claps like me, like some jerk here being like, yeah, I think patients are great. And of course, well, I got to actually do something about it. Patients have been fighting for a long time to get their records and to get things like this, and it hasn't happened. So it's not going to happen by magic or just by saying it'd be nice. There actually needs to be real things happen. Real things need to happen. And Josh Mandel, who's a very smart man, wrote this as well about number 3.
He just seemed pretty smart. He was like, hey, there's going to be some stuff going on. I hear this guy is actually pretty fucking smart. He is. But yeah, also like individual access, remember, it was not made mandatory under TEFCA, which is kind of bullshit. And that was going to be the great reason TEFCA was useful. And that's kind of a bummer. So hopefully, everybody knows, like, I don't know if TEFCA is going to stick around because it depends on who's going to be the national coordinator. But I do think that if it does, can someone please make individual access like a priority and like a real thing? That would be awesome.
What Grace is saying here is, when requested and medically necessary information is not being exchanged, right? Like, this is the problem, is like, what is it going to do? What is it going to do for you as a patient if you get some kind of ping, some kind of alert that, like Jim Bob, like radiologist, has like requested your records for this from your insurance company? Like, I guess something that something might be moving, but you don't know what it is necessarily. And the bigger issue for patients is that the bigger issue for them is that they're not getting the information they requested and need to have happen. They're trying to shepherd their records from like B2B player 1 to B2B player 2. They're not in charge. They're not the center of that. They don't have the power there. That doesn't achieve this. We need patients to be able to be the drivers of this work. And yes, Liz rightfully points out that like responses aren't coming under individual access service. Pisses me off too.
We're freaking pissed off too, girl. Anyway, so I'll say, I mean, the other thing that I should have said is one of the things that's going on in the Trump administration, while there is great doubt that TEFCA will make it in any sort of substantive format, and we'll see what happens, right? Because like, who even knows these days? If Medicare Advantage for All becomes any sort of a thing, that requires a lot of transparency. So there might be more of a reason to focus on TEFCA or something TEFCA like. So that could be a thing. Also want to shout out to our friend Don Rucker, who was basically like WTF and agrees with Josh on this, that we have to, like, that would provide real trust in TEFCA if patients were notified when their data was sent around. But also, pro API over here. So anyway, God bless Don Rucker. So, all right, what do we have going on? Oh, and then speaking, so, Don here talked about trust and all that. So speaking of trust, we've heard a bunch of rumors that all of Health Girl's leadership has been dismantled.
Exited?
That's what we exited. Dismantled, exited, TBD. Melissa Danino is nodding. Must be true. Okay. But we did see on the LinkedIn that Dave Passel, who was formerly something, I think he was something CTO, CIO, I forget, something at Health Girl. He's now at Innovacer. I think Stephen Lane sent us a note that he has retired and gone back to clinical care. We heard Steve Yaskin is no longer with the company. So yeah, seems not great, but
I think it raises the question of, I think leadership can change in any kind of company or organization, right? But this is kind of going back to the previous comment from Don Rucker about just trust me. Well, that is a company that is a QHIN and a QHIO here in California, the Data Exchange Framework. And so, what are the things that the various, bodies who are selecting and maintaining the QHIN status or the QHIO status, the QHIO status of these organizations or companies, what are they doing? What do they require to know that a company or an organization has, the governance and the support and the structure to be in that critical role as one of those decentralized hubs of a national network that is endorsed by the federal government? I'd love to know. I haven't really gotten a good answer there. I think I would go back to when all of these things were being considered, they were being structured and considered in different ways, and having companies and organizations who don't meet the sort of original criteria or characteristics of a QHIN as originally, designed or designated. This is the kind of problem that you have, right? Venture-backed companies are they're not terribly stable necessarily. They're going through growth phases. They have leadership changes. They have governance changes, and so these are all questions that I would be asking if I were in charge of this.
And they have reputation challenges. So moving on, let's bring Dan back up to the stage, because Dan, now we're going to talk about America. And
amazing.
We probably won't. I don't think we'll get you in too much trouble. Maybe we will. If we do, you can remove yourself from the stage. So, so yeah, Lisa, so what we were talking about, because there's been all this, I'd say 80% of our text threads these days on the back channel is about who's getting appointed for what and what is happening in Donald Trump's new administration. And what I've been telling people about all these rumors, sorry, I should have been up there, but this is a budget show, is go on vacation. Go on vacation for the next month, y'all. Because be like Kat, go somewhere, drink the champagne, drink the wine, and just enjoy yourself, because we have no fucking idea what's going to happen at any given moment. As previously noted, everybody thought Bobby Jindal was going to be the secretary of HHS, and guess what? Then he wasn't, and it was RFK. So,
and he wasn't.
And then everybody thought everybody else was going to, or Paul Mingo was going to be CMS administrator. Then he wasn't. Now it's Dr. Oz. So anyway, what's word on the street with Medicare Advantage for All, Lisa? I feel like you had some things to say about Medicare Advantage for All.
I mean, listen, as we know, as everyone is sort of saying in response to this, the extremely negative backlash to the murder of the United Health executive, we spend a disgusting amount of money on healthcare and have really, really terrible coverage, and people fall through the gaps all the time. Some of that is what, Dan and Reimagine Care deal with from the cancer side, and people just falling through the gaps and not getting the right treatments, and all having to fight forever for getting approval for their treatments and all kinds of stuff like that. We have essentially a private version of Medicare that a lot of Medicare beneficiaries use, which is basically private insurance that has slightly more stringent requirements and more generous coverage. And, there have been some questions about the cost and the quality of that care that, people rightfully debate in both directions. But Medicare Advantage for All is definitely one of the proposals that floated around over the last, 2 decades about how we could actually cover more people. And that is private insurance with this Medicare backstop and these Medicare requirements. It's just like a buy-in to Medicare in many ways. It could be structured in that way. In the past, Dr. Oz has talked about this as positively mention Medicare Advantage for all. Who knows what he's walking into this new administration with? Who even knows? Who knows what RFK Jr. thinks about Medicare Advantage for all or Medicare for all? Personally, I'm more of a Medicaid for all kind of person. I think that, you know, because our country has 50 states and a number of territories and DC and whatever else, like we really we need care that's more appropriate for where people actually live and what they do. But whatever, I'll take it. You know what, Kat? If Medicare Advantage for all comes down the pike, I'm going to be yes, Medicare Advantage for all.
Okay. Well, Dan, so how is Medicare Advantage for all? Is it theoretically, because I know we don't have any details, is it a good thing for cancer care and it is a good thing for telehealth? Like two separate things. Like, tell us what you think about that.
Well, that's a good question. I'll go back to what you said earlier about vacation. How long are we supposed to take vacations for? Is it like 4 years or
at least a month?
At least a month. I mean, you can be gone for 4 years. I'll still be here, so you call me. But like everyone should just go away for a month. Like it's fine.
Yeah,
it's fine.
Yeah, exactly. We'll come back and we'll figure it all out. Okay. So with that being said, I think, you know, listen, Medicare Advantage for all. There's going to be benefits. There's going to be, you know, drawbacks. There's all sorts of stuff on this. I think from a cancer care perspective, you know, it's more about making sure that patients get the right care that they need in the moment. And I think a lot of this is like, that's what we're trying to focus on, is helping to support them, be the extension of those, you know, providers, you know, to support them in the home and on the go. And, you know, I think the future of telehealth is kind of out there at risk as well. And I think, you know, Dr. Oz and his plans, I mean, we'll see. You know, I'm not entirely sure. It's not going to happen overnight. I think it's a long drawn out conversation to even remotely get anywhere with that. But, you know, from a cancer care perspective, I think there could be potential benefits there.
Health. Why do you think it's a risk?
Well, I mean, there's the data out there proving that it's not being adopted as much. Like obviously a huge peak during the pandemic, and then it's starting to kind of draw back. You know, I think the you know, site of care reimbursement is out there potentially to be changing too. And so I think that's where there's that unknown of where is this going to be in 2025 moving forward. And I think that's the big challenge. I think there's a lot of programs that have been built around it, and I think it has huge outcomes. It's a matter of like, can we get the right reimbursement to make it a reality and make it actually sustainable moving forward?
Well, on the telehealth side, there is literally a immediate you know, risk in that I guess the DEA did agree to extend for a year, but it's not sort of finalized. We don't have a final rule that, you know, has specific guidelines for how you can do controlled substances prescribing via telehealth on a longer term basis. It's still in sort of like, you know, provisional area, and people aren't totally convinced either way what's right, what the right way to do it is and how we should do this. Been lots of questions about, does telehealth drive, you know, low quality care? That seems to be, with evidence being pushed back on pretty seriously, that that's not the case, that telehealth does in fact drive high quality care, doesn't drive like, you know, poor, like unhelpful utilization of care or whatever, low quality care. There are a bunch of extensions of things that are being negotiated right now in Congress in the lame duck session that could include things like extensions of various telehealth flexibilities. I think they're like hot in negotiations right now. We don't know where it's going to land. So I guess I would say, I mean, I think part of it is going to be where these sort of temporary negotiations take us, but then also like, yeah, what does Congress do next year? What does the administration do? What do they push for? We have no idea what their positions are, because their positions are totally new. Who knows? Have they done this before? I don't know.
That's why we'll find out. Take a vacation for a month and come back.
A vacation.
Yeah.
Lisa, that's a really good point about the quality. And I think there's always bad actors, right? There's people that are going to find ways to, you know, bend the rules or, you know, live within the rules, but still just benefit themselves, right? So you're always going to have that no matter what program you end up with. But I mean, certainly the world we're living in, we have seen amazing outcomes being able to support patients remotely, right? And we can't just keep building brick and mortar locations. We can't just keep hiring people to support patients in person. We have to be able to use technology and virtual support to, you know, meet patients where they are and where they want to be met. So I think we have to be able to figure out ways to do this at scale.
So, Lisa, isn't Medicare Advantage law? Wouldn't that require an act of Congress?
Yes, all of us require a law, which is like never going to happen. Like law,
right? So that's like okay. Yeah. So like, can we just talk about like so just because you bring in a guy and you appoint a guy who like loves the idea doesn't mean like they get to like make the idea. Like this is not the private sector as much as I wish it was. So like, yeah, like likelihood that this is all going to happen. Like what's the over under on that?
So low. I mean, it's vanishingly low. So I think we just got the final numbers that the margins in Congress that Speaker Johnson is dealing with is like 220 to 215. So like 220 Republicans and 215 Democrats. So to be fair, like a shout out to Mike Johnson, because he has actually managed to keep the government open. He's been doing all these things, right? And he's done that because he's gotten Democrats to vote with him. And that's not going away because he literally will not be able to do anything. Like there's going to be at least a couple people in his own caucus who are like, no, I don't like that. So he has to get Democrats to vote with him. And I mean, they would have to do, I would imagine they have to do a lot to get Democrats to be on board with whatever plan for this is. However, Medicare for all, Medicare Advantage for all, I mean, that's a very like liberal progressive idea. So who knows?
Yeah, it's totally wild. It's totally wild. But you know, we got a bunch of private sector people administrating it, competing for margin. You know, I wouldn't be super mad about it. So, all right, let's buzz through our next couple slides because then I just want to ask Dan about what he thinks about prior auth. Okay, so all right, the Doge. So Lisa, what have we heard about the Doge and what it's coming for? We've heard it's coming for a lot. It's coming for 75% of federal employees' jobs, apparently, and $2 trillion in overall federal budget reductions.
Okay, once again, like this is not how the government works. I mean, but however, like if they can get people in Congress to like be interested and think about passing some laws, like they might be able to actually do things. And you know, and that's not out of the question, right? What I said before, which I'll say now yet again, is that the Government Accountability Office already exists. And they're an independent agency of Congress. Like they're not part of the executive branch, they're part of Congress. And they do these really great reports where they spend months and months and months like investigating and researching the like functioning of the federal government. And they have these recommendations for how to make things better and like less crummy and like waste less money and do better work. You could just go through it and implement like their recommendations.
Lisa, what I'm hearing you say is that because no one reads these reports, we should just cut that entire agency.
No, they're not. They're doing good work. They're amazing. They write great stuff and people should just freaking do them. You know what stops it? It's just like the like roadblocks in the administration, roadblocks in Congress, nobody wanting to actually like do the hard things. By the way, there's a lot of Medicare fraud, waste, and abuse. Let's cut that. Speaking of, Dan mentioned, you know, that there's some bad actors who use telehealth for things. Well, there you go.
Yeah. Hey, Dan, what do you think is going to be cut? What would you tell Elon and Vivek to go cut?
Oh, yeah, the fraud and abuse. I like that one too. But it's I just think this whole thing is slightly ridiculous. Like this whole organization, they're like
slightly. It's called Doge. Like it is like the most ridiculous, amazing thing I've ever heard of. Like
there's a meme like Bitcoin, like this. I don't know, whatever. This whole thing is. It's like, but they're not like. That's right, Dogecoin. So, but they're not going to like have any actual real like control. It's just like hey, here's some people, like Lisa just said, there's already an organization that does this. We're just going to have someone outside who's really smart that everyone knows and is in the limelight all the time. We're just going to have him put his recommendations together, and we may or may not do any of those. But it's like the whole thing. The funny thing is actually, Lisa, it'll be really great when they come back with their list of recommendations, pair them up with the internal organization and see like how much
GAO. Yeah. Right? Yeah. I mean, the problem with the federal government is that a lot of the funding is mandatory, and it's mandatory on things like Social Security payments, on Medicare, which not the weird things on the fringe, but like literally just like basic paying for Medicare. And then it's defense. It's the Department of Defense. And there's lots of stuff has been written about like waste, fraud, abuse, double, triple, quadruple payments there. But like, it's not very politically popular to be like, we're going to cut the Department of Defense. Like nobody wants to hear that. Nobody wants to hear that. It's not like sheep centers of excellence, which is the one thing he was like, I think Elon was going on about like, oh, we pay for like a sheep center of excellence. It's like, yeah, because like we have a pretty big agricultural sector and like people raise sheep and it's like a thing the government's like, that's not actually that weird. Like that's like kind of normal and people really, and farmers really like that. So like, what are you going to cut?
Well, and they said, isn't their goal like to cut like $2 trillion, something like a third, right? So
then you're cutting military spending. So just like be good with that.
Social Security and Medicare and Medicaid make up 2/3. So what you just say, we have to do that, right? So what are you just going to cut everything else? Like seriously?
Yeah, sure.
It's just okay.
It's not realistic. And there is a lot of waste and probably there are things you could cut, but it's not going to be $2 trillion.
No.
We are a massive country. We are a very rich country. We have a lot of people who are receiving retirement benefits of various types. Like those are things that we made a promise to people for like paying their taxes for their entire life to pay. Like these are just not things you can necessarily do. Now, on the federal employee side, it's even more ridiculous, right? Because there are not actually that many federal employees. Thanks. Yeah, we can cut more than everything away. That's correct. We don't have many federal employees. We have about 2 million of them. We have lots of federal contractors. We can probably cut some of them, but the federal employees are not actually that expensive or there aren't that many of them. And if, by the way, if you fired, which you can't do, if you fired 2 million people, you would throw your economy into a depression. Like it wouldn't be just a recession. You'd be like, you would be screwed. Like you would be in the garbage with that. Like immediately 2 million people, you'd be in the garbage. You can't do it. Anyway, what you can do is you can kind of like you can give the vibe to federal employees, they should like retire early. You can give them an early retirement package. You can do things like that you can say 5-day return to office. You can do things that are going to be hard, are going to be a fight, and they're not going to achieve what you want to achieve. You're not going to have all the bad people, by the way. It's the same as any workplace. There are good people, bad people, medium people, people who are neutral. There's not like a bunch of bad employees. There are people who work really hard in the federal government. It's not just the bad people who are going to leave if you ask for early retirement. You're going to have a real problem delivering on the services you need to do for the American people every day. So blah, blah, blah. My point is like, it's not that easy, obviously.
Well, here's what I'll say about like, having handled a lot of M&A and stuff like that. If you're just, Kevin, freaking love
That's
this
right.
guy.
Kevin's joining Doge.
I do agree. I do. Well, I actually, I'm kind of pro Doge over here. Like I'm kind of into it. Like I'm kind of into it in general, just given who I am. But I do think like there is a problem when you soft force people out, like when you say return to office or you just make certain things harder, or you change requirements. What happens is the really good people could have left a long time ago, and they're going to go and they're going to become McKinsey consultants and make 4 times their salaries. Right? That's what they're all going to fucking do. So the ones who are left are the ones who aren't going to go anywhere because they have nowhere to go and they're just waiting for you to fire them. Like that is how this works. So yeah, like I do hope if they're going to do a real riff in the government, like they're mindful about it and don't just do one of these forcing mechanisms, because you will lose all your good people. And Lisa, like, well, Dan, probably even you, all of us have heard every day we probably get how many inquiries? At least 5 inquiries from a good federal government person asking if they can join your team because they're like, I got to get the hell out of here ASAP because crazy shit's going to happen, right? So you are going to lose incredible people. So I hope that they're just like smart about that.
Well, and it's funny. You mentioned one of the earlier topics around like a comms kind of mess up. Like I think there's the chat going on here. Kevin and Kelly are commenting on this. Like I actually think it's right. If this could have just been like a little bit of a bad comms type of approach. If they said, hey, we're going to bring in some really smart people, outsider perspective, give us an additional like way of looking at this, maybe from a different angle, a little bit of a deeper dive. Okay, fine. But to come in and the way it's set up and the way it said, we're just going to cut $2 trillion and these are the smart people that are going to do it. That's where I think the comms kind of messed up. So I think there is actually an opportunity.
The messengers are not very credible for obvious reasons, right? Like Elon Musk is a huge federal contractor. He gets billions and billions and billions of dollars from the federal government. So I don't know that he is the right person for this message. And I also think, so Kevin wants to be on the show. I feel like, I don't know. He says something we talked about. It's true. He does get press. Elon gets press.
Yeah.
I'm pro Doge. Like I am pro. There is objectively a shit ton of waste in the federal government. A shit ton. Like, if they can find that and effectively remove it, great. Like, I'm here for it. But again, I do think that like they have to be mindful about it, because you're going to lose incredible people if you just do the hammer and the nail approach.
There are really, honestly, incredibly great people who work their butts off for not a ton of money in the federal government. And of course, there are people who are a waste of space, just like in any company, private sector, public sector. Nobody has like a whatever. Well, my team is incredible, but we're a very small team. But bigger companies are like, there's plenty of, if you've worked at a big corporation, like you have probably worked with someone who was like, what does this person do here? Like, why are we all working around them? Same thing. It's a big, big organization.
Yeah. But whatever. I hear, we've heard a lot of different things. We've heard Doge is coming for ASTP. We've heard they're coming for ARPA-H. We've heard they're coming for freaking everybody and anyone. So who knows what's going to happen here. I think what I did read today is it's unlikely they're going to like just abolish whole agencies because that would be hard, but they might do things to cut them back. So whatever, we'll see what happens there. So and then last thing that we'll say before we actually let Dan talk for real is just like, can you just bring back Don, y'all? Like, just
we'd be good with that.
Like, Don's great. Like, Don is going to do stuff. He's like pro private sector. Like, the wheels stayed on the bus. Like, can we just have one comfort item here? Can we just have one? Let us bring our favorite blanket with us. Let us sleep at night. And then the final thing that I'll say before, again, we let Dan talk and hopefully don't get him in trouble, is this is not actually about Mitt Romney. But what I want to say is, like, there are all these lists out there about like top all kinds of people, lots of top women. Listen, I just want to say Lisa and I have binders full of women, and we're going to do our own top 10 best women in health IT lists, and it's going to be freaking fantastic. And much like all other lists, full of all of our friends. So we're ready to go.
But also, like, on that note, like all of those like top whatever lists, like everyone knows, in case you don't know, like those are pretty much 100% people's PR people paying to be on those lists. We're not accepting payment for this list. This is our list because of what we actually think, who we think are the best people. So this is the only real list.
For other things.
The other lists are all fake. Our list is the only real list. So just if you're like, how do I know who are the top? It's us. It's our
just who we got our opinion on those things. So yeah. Okay. All right.
No payment.
Okay, Dan, like, listen, I'm sorry. What do you want to tell us?
There's a lot of different ways we could take this.
Do you think prior auth should be abolished for oncology?
Yeah.
Ooh, good question. It's funny. It goes back to the same comment earlier. Like, there's bad actors, right? There was, listen, prior auth was put in with well intentions, right, to help catch the bad actors. And so, at the same time, it's bloated into this massive thing that delays care. And, one of the proven things for patients going through cancer treatment is from initial diagnosis to when treatment begins, the closer that gap is, the outcomes are proven to be so much better. And whether it's prior auth or just even being able to get in to see an oncologist, like, those delays end up being months, right? And so you go from having a diagnosis and then not being able to actually see anyone, whether, again, for all those different reasons. And then you finally say, okay, now I'm talking with someone, I'm going to get my treatment, or maybe it's a second opinion, which then takes longer, or whatever else it is. So you're now maybe 2, 3, 4 months down to when your initial diagnosis happens. And, as a patient, like, just the angst, the stress, the unknown, like oh my God, I've got this, I have cancer now. And you're just like hammering on Google, trying to do your own research because you can't get your own answers. So I'm just saying, whether it's prior auth or whether it's just the ability to get patients in faster, all of that needs to be solved, and for cancer specifically.
Like, the patient journey is just awful, isn't it?
It's not ideal. Now, what I would say, like, there are some wonderful organizations that are solving different parts of this, right? And I'm not even talking about Reimagine Care. I'm just talking about, like, there are organizations that help on the initial diagnosis, second opinions, the burgeoning kind of genomics and genetics, and like really understanding that. Like there's so many great organizations out there. So many great organizations like actually providing the care. All sorts of wonderful oncologists and larger health systems, comprehensive cancer centers, City of Hope, Moffitt, Sloan Kettering, et cetera. But we're all doing it in pieces. And I think that's like going back, Kat, to your point of like the patient experience is disjointed, right? And there's not that coherent ability to support patients from the very beginning all the way to hopefully survivorship. Like that's what leads to a really bad patient experience.
Yeah.
So
I think badass on Grace's, let me just bring that up again really quickly.
Yeah.
Really into this one, denials in care and prior authorization documented and considered as legally recognized causes of death for death certificates. I mean, listen, there's some realness in that one. It matters, right? The time that you spend, the time that your family spends fighting to get the care that you need, right? Everything else aside that you just said, which is totally true. There are bad actors. There are, unhelpful treatments. There are people profiteering in this space. But like the reality is with cancer, the time that you spend absolutely can lead to your death.
Yeah.
And it's not only the time in that initial between diagnosis and treatment, it's also just the time toxicity that happens in general, right? Just cancer care is a huge
sponsored by Diet Coke, probably a carcinogen.
So it's not, it's
get your crystal, Lisa. Me and RFK, we have all kinds of alternative therapies. So
it's a whole new business model.
Keep going.
So, no, it's a whole new business model. We're gonna have that. We'll do the ads. T-shirts will be made next week.
Got it. Awesome.
So, it's the time toxicity for the patient, for the caregiver, for the provider. There's so much waste in the system. You talked about, waste in organizations, right? There's slack. There's slack in organizations, just like there is in our ability to deliver care for these patients. Mm-hmm. And so that's something, if we can like close those gaps, I mean, that's what we're focused on, right? For patients that are in treatment, being able to meet patients where they're at in the moment, whether it's 2 a.m. or middle of the day, whatever it is, like you've got access, and that I think is a big driver in supporting like the removal of this time toxicity, but it's going to take more than just Reimagine Care. Like there's so much more across the system.
So Dan, the whole patient journey is like totally bullshit. And there's lots of frustrations for like everyone involved, right? Physicians can't get things done. Health plans don't know what's going on. Patients are like freaking out. Their families are freaking out. If you could cut one friction point out of a patient's journey when they have cancer, what would it be?
Ooh. I'm going to do 2. Right. My team likes to.
All right. That's fine. I mean, we're not great at rules over here, so that's cool.
I like one, I think is that initial gap, right? If we can find out a way to get people from initial diagnosis to treatment, like within days, not weeks or months, that's going to be a huge win and lead to better outcomes. So I think that's one. I think also the ability for patients to get answers in real time. And again, this kind of comes back to what I was just mentioning, right? So our solution, but let's just say it's not just Reimagine Care. In general, from a patient experience, you've had your most recent round of chemo, several days later, you're starting to have some reactions, symptoms. It doesn't matter what time of day or what day of the week, whatever else it is, you're going to call in, right? In the traditional healthcare system, you're going to call in, you're going to get maybe go through a phone IVF system, right? Picking numbers, everything else, trying to get connected to a nurse. Maybe they'll call you back. Maybe they won't. It's the middle of the night. You might be paging someone, but either way, you're going hours without getting answers, right? And then your symptoms, what are they doing? They're not just staying the same. They're not just magically getting better. They're escalating, right? And so if you had gotten an answer immediately when you needed it, when your symptoms were maybe a 3, 4, or 5 out of a 10 on severity, but now you go several hours or a day before you actually get an answer. Now you're at an 8 or 9. What are you going to do? You're going to go to an urgent care. You're going to go to an ED. You're going to cause yourself more money and the entire healthcare system more money and waste. And so that's like, when you talk about the biggest barrier, like the first one is that initial gap to treatment. And I think the next one is just getting answers in the moment. We should be able to meet patients where they're at 24/7.
So who's going to make less money if those 2 things happen?
That's okay. So the funny thing is I don't know. Well, all right, I'll tell you what. Since it's late on a Friday, depending on certain health system CFOs, sorry, emergency rooms are a revenue center in some cases, right? The fee-for-service world we're in. And so you start having these conversations about, oh, we can reduce your ED visits and all this stuff. Well, some people are going to start to say, maybe they won't say it publicly, but they're going to start thinking about like, okay, well, if I'm reducing my ED visits, that's actually revenue that's you're going to be taking out too. So there's one. Again, most won't admit that publicly, but I think that is one of the most obvious ones.
Yeah. And then the delay between diagnosis and treatment, like who makes less money there? Because it sounds like that just sounds like bullshit admin, right? Like a health plan's still going to pay, right? Only they may be paying when the condition is worse, which doesn't have them win. Is it providers who make less money with the delay, or is that just bullshit in general?
I think that's just bullshit. I don't know that you're really causing anyone. It's just a supply and demand issue, right? We talk about this all the time. Healthcare in general has a supply and demand issue, but cancer care is even more magnified, right? Because patients are being diagnosed younger in age, like earlier in life. Treatments have gotten so much better, so patients are living longer. That's a great thing. But those two combinations, like what do they do? It's leading to a huge increase in demand of cancer care. On the supply side, we have burnout. We know RNs are leaving the workforce in droves, right? They're burnt out of being in clinic. 93% of oncologists have admitted to having to work off hours just to keep up. So you got this like growing supply and demand gap, right? And so that's what's leading to a lot of this. We don't have enough people to see these patients quick enough, and we haven't built the right technology solutions to bridge those gaps better. So,
yeah.
And I mean, and I if you can keep people in a non-crisis state, then you should be reducing the demand for those crisis response resources in emergency rooms and so on and so forth. But like you said, I mean, there is, those are the highest, those encounters cost a lot of money and somebody gets paid a lot of money for that. It's not like good or positive or something people individually want to have happen or want to have to treat, but like, there is money there, I guess. But like you said, people are living longer. So there's more lifespan for them to, be consuming healthcare services. So you would think, I think maybe it's the temporal nature of it that is going to get you in trouble in the sense of like, well, there's not going to be any need for, or it's going to be much of a need for emergency intervention services. But over time, there's a need for many more services. Someone's going to be alive for much longer. And there's huge benefits beyond just the economic benefits that we can calculate. So it feels like incentives being aligned slightly differently. But then if you go to like, can we please make like the outcome be that we're getting paid when people, stay healthy and don't go into those crisis points. That's just, we're all trying to do that.
Well, and that's the transition to value-based care, right? So, I mean, the entire health system, we've been on this very slow march to value-based care. And cancer care has been even slower because of the variability. It's not one condition, right? It's hundreds. And so, that's been hard to really build these value-based arrangements that will actually be successful in cancer care. But I think that some of those are starting to evolve, and we're working on building this out as well. And the programs like this help the entire system. So as we are able to support the adoption of these, it's going to help be a glide path for value-based care, specifically in cancer for our case. So.
All right, Dan. So I know you said you may take a vacation for 4 years. Like I said, I'll be waiting for you. I'll be here when you come back. But assuming you can't, like all of us, what are you most excited about? Because listen, y'all, this is the world we're in right now. We gotta live in this world. So what are you actually most excited about with the Trump administration with regard to Reimagine Care and cancer care?
That is a really good question. Put me on the spot with that one. Honestly, I think like from the Trump administration, the administration in general doesn't necessarily really matter. Like I think from our perspective, like we're building a company that is going to be extremely successful in supporting the mission of cancer care delivery. And so like Republican, Democrat didn't necessarily matter. So I'm going to dodge your question a little bit and say, I actually don't care. We're going to have a great 25 and beyond anyways. I think that's what we have built now and where we're positioned with existing provider and amazing, partnerships we have with our providers. And then transitioning this next phase of growth and getting into, pulling in these risk-bearing entities and the payers and really figuring out like these right alternative payment models, like that's the exciting part. And that's where we're going to start to see some actual improvements in healthcare delivery.
All right. Well, parting words for all of America who are definitely watching the Health Tech Talk Show right now, all of them.
Parting words. Really just appreciate the opportunity to share a little bit about what we're doing. I mean, I think I love this format. It's always fun. And it's just a great opportunity. But, I think the biggest thing we talked about, like, let's go knock down some of these barriers. You mentioned earlier the Spider-Man meme, everyone's pointing at each other. Like,
that's right.
Like, how do we work together? Right. Like, how do we stop like trying to just like protect our own fiefdoms and make our own money? Like, how do we actually say, like, let's figure out with these big players, how do we come together and actually solve something meaningful instead of just fucking around trying to like make a buck on our own?
Yeah.
That's my plea to the entire healthcare system is like, let's just be better. Cause right now we're not.
Yeah. That was really good. Yeah. That's kind of like in the middle of me and Lisa.
Yeah.
We hear you.
Oh,
we hear you. Well, thank you, Dan. You're awesome. Thanks you for being
Dan.
a guest. You knew what you were getting into, so it's even a bigger risk because you were like, "Well,
even better."
But yeah, thanks for hanging out with us, and hopefully we didn't get you in trouble with your investors or anyone else. So we're excited to continue talking to you. And Lisa, any parting words?
I mean, go on vacation. It's good. And all the rumors you're hearing right now, they're just rumors. Just like, let's wait and see. Tinfoil hat on or off. Just
be like Kat.
Go on vacation.
Start drinking the wine. Go on vacation. Tell us about it. Come on the talk show and tell us about your vacations. It's going to be awesome.
That's right.
And we'll see what's going on. Oh, wait, we do have one guest comment. Kevin would like to know what Transformers are on your shelf.
Yeah.
Oh, all right. So we have Optimus Prime, but then the other one's Voltron, which is not technically a Transformer officially of the Transformer thing, but
yeah,
that's good.
Nice. I was made in the 80s, so I kind of know what's going on here. All right. Goodbye, America. We'll see you next week. We'll see you next week.
Thanks, Dan.
Bye, everyone.
Bye.